Welcome to the Pediatric APHRS meeting, all about CPVT. I appreciate that so many people can attend today in those difficult times when COVID-19 is probably putting a huge load on the health system. And so I would especially thank those people who are, already working so hard behind the scenes to make this possible. Especially, I would like to thank the APHRS for the support of the pediatric group, and specifically Professor Apichai Kongpata-Nayotin for his strong support and pushing this forward. I think we wouldn't have been doing that today if he wouldn't push so hard. He's really the person who's driving pediatric EP in the APHRS currently. I also would like to thank Jimmy Yap for the technical work behind all of it, and all other speakers for the engagement today. I think all of you, most of you attending today have been attending a virtual meeting, so you have this Q&A function on your bottom line, and we encourage you to ask questions. We will first go through all the talks and then try to group the questions and get everyone involved. The theme today is, as I mentioned, CPVT. My colleague Andrew Davis also calls this the very sneaky disease, and we will hear about it a lot, why it's so difficult to diagnose. And a good sign that it's so difficult to diagnose is that the average time between the first event and diagnosis in most patients is a few years, actually, and that of course gives a huge possibility of having another event, and we know that it can be a deadly event. So without much further ado, I would like to introduce my co-chair, Dr. Sachin Yalagudri, who will introduce the first speaker. Thank you.
Good morning, everyone. Thanks, APHRS, for the hosting CPVT symposium today. We're happy to introduce Dr. Apichai, who is chairing APHRS and the Pediatric Electrophysiology. He's a pediatric cardiologist from Bangkok. Presently, he holds a position in Bangkok General Hospital. He's the Chief of Pediatric Cardiology. He's a Professor of Pediatrics and Faculty of Medicine in University of Thailand. He's a Professor of Clinical Pediatrics, Keck School of Medicine, University of Southern California. His special interests are pediatric cardiac arrhythmias, genetics of heart disease, and pediatric cardiac intensive care. So he's trained in internal medicine, he's trained in cardiogenetics, he's trained in pediatric cardiology, and he's trained in medicine and pediatrics as well. So he's a man behind arranging this CPVT symposium today. We'll all welcome and listen to him from the diagnosis of CPVT and its differential diagnosis. Without much delay, I'll ask Dr. Apichai to start his talk.
You're still muted. Apichai, you're muted.
Okay, all right, thanks. Thanks, Angus and Sachin. I'm honored to be here. So without further delay, I'll just put my slide up. I have no disclosure. So this is CPVT, first or very early description. It's 1995, so it's a relatively new diseases. CPVT had a prevalence of 1 in 10,000, so roughly about a fifth of patient with long QT syndrome, and that's what we see too. Essentially, it's a condition that, well, the first description is that a patient went to exercise, usually a shower, and then went to polymorphic and bidirectional VT. And when you look at the heart is structurally normal, And at that time, I think most people know about long QT syndrome and the VT associated with it, but these patients had normal QT, and sometimes we have a little bit of bradycardia, but essentially a normal EKG. The age of the CPVT is known to be a disease of childhood, usually presented at around 10-year age, a little earlier in boy compared in girl. So presentation usually exercise-induced syncope or sometimes a seizure-like activity after cardiac arrest. 30% of patients can present with cardiac arrest. Mortality is high if untreated, and it was estimated to be 30% before 40 years old. So this is a symptom-free survival of a larger group of CPVT that was put out by international registry study. And you can see that most patients would have symptoms before the age of 40. And it has been said that if you have symptoms started after the age of 40, then you should think about some other disease like coronary artery, and CPVT would be low on the list, although, you know, I've seen a mother of the child with CPVT who actually said that she never had any symptom, but she had VT when she exercises. So this is EKG, one of my patients. If you look at it, it's pretty normal. And when we put the patient on a treadmill, you sort of see things like this. So it would be, as the name implies, a polymorphic VT during exercise. And a lot of time it will go to something like this, which had a VT that changed direction from one to the other, so-called bidirectional VT, and that's a signature of CPVT. Most of the patients that I see do have at some time bidirectional VT associated with exercise. The etiology of CPVT, now we know that the pathophysiology is excess in intracellular calcium, and that leads to delay after depolarization and trigger ventricular ectopy and then VT, and then if it go on, it go to VF. CPVT is a disease known to be a channelopathy, so meaning most patients would have mutation in one of the genes that control the release of calcium in the cell. Traditionally, it's a RYR2, and some people call it CPVT1. It's a ryanodine receptor channel. It caused too much release of calcium during depolarization. CPVT2 was discovered later in a family with CASQ2, homozygous CASQ2 mutation, and that comprised about 2 to 5%. And Andrew is going to talk more on genetics, so I'll just skip here. There are some other genes, but those are rare. So this is how you get CPVT. It's ryanodine here, which control the release of calcium from sarcoplasmic reticulum. So during the depolarization, if patient had problem with calcium release control and release more calcium, then you have polymorphic VT and bidirectional VT. Actually, bidirectional VT is something that you can see in patient with digitalis toxicity, which, as you know, will cause more calcium to go into the cell, and if it's in the toxic range, and you can get CPVT as well. And the calcium that is released would trigger activity in the phase 4 of depolarization. So we call it delay after depolarization. And when it reaches a threshold, it will present as a PVC and then go on as a VT. So essentially, the child that present with CPVT, if it's not from family screening, will be someone who either had syncope or cardiac arrest with exercise. And obviously, you go ahead and do echocardiogram, and you find structurally normal heart. Then when you do ECG, you look for QT, and then QT interval would be normal. You can see sinus bradycardia in about 20%. Some patient had atrial arrhythmia, AF6 sinus syndrome. Some patient will have a prominent U wave, but I'll show you later if you have someone present like CPVT and prominent U wave, and especially if QT is long, there's Anderson Tawil, which is a long QT7, which oftentimes present with something that looks like CPVT, meaning bidirectional VT. So obviously, if you do both of these, either echo and MRI and then ECG, and things looks normal, and the patient had event during exercise, then you would go ahead with exercise stress test. The sensitivity is fairly high at 97%. I'm sorry, as 50% specificity is fairly high, 97%. So if you put someone and get a polymorphic or bidirectional VT, then you can diagnose it pretty much. Sensitivity on one of the study said it was 50%. I personally, I think it's probably more than that. Although, you know, if you have a variant carrier that doesn't have VT, then you can have a sensitivity of 50%. But if you have symptomatic patient, usually you see something at least PVC or couplets, if not VT. Generally, what I see is that a patient will be fine at rest. PVC will start once the heart rate go beyond 100, and then progress to polymorphic or bidirectional VT at a higher stage. And a lot of time patient had VT, and then they actually said they were fine and don't have any problem. You know, the one who actually had problem is the one doing the test. If you don't see it before, because it looks scary sometimes. But a good thing is if you stop exercise, things will get better pretty quickly. And then once the heart rate go below 100, then usually VT would go away. The signature arrhythmia of CPVT is bidirectional VT. So if you have a bidirectional VT and all this, then it's pretty much CPVT. If you have polymorphic VT, it's also technically called CPVT, but I think you have to also be careful and look at some other thing like coronary artery origin and that kind of thing. So this is one of the patient. This is at rest, and when we do exercise stress test, patient started with few PVC and then turned to couplets and then turned to, you know, bidirectional VT. And then when we stop, the VT will reverse and go back to normal. Other investigation that might be helpful, Holter monitor, you can see polymorphic VT during the heart rate that is high. So a lot of time, if you see a heart rate of the patient that go up to 150 and 160, you don't see PVC. That's pretty much say that it's probably not CPVT. Although I must say sensitivity of the test is not 100%, even exercise stress test. There were cases that I heard of the first time you do exercise stress test and there was nothing, and then it was discovered later that the patient had CPVT. In the patient who cannot exercise, you can do adrenaline infusion test, but sensitivity in this case is pretty much not as good as exercise stress test, although specificity is pretty much the same. You can do genetic testing once the diagnosis is diagnosed by exercise stress test. And I think Andrew will talk about, what if exercise stress test is equivocal or negative. There's a pro and con of genetic testing for doing something that in patient who is phenotypically not solid as a diagnosis. For differential diagnosis, essentially you'll be looking at exercise-induced polymorphic VT, so long QT syndrome, coronary abnormality, abnormal origin essentially, or post-Kawasaki, ARVD, arrhythmogenic right ventricular dysplasia, a variety of cardiomyopathy that sometimes echo can be looking normal. So a lot of time we do MRI to confirm that the heart is actually normal. Idiopathic VF, Brugada syndrome, actually, it's usually you don't have exercise-induced VT, although we have seen cases of that. And also for bidirectional VT, there is a Anderson-Tawil syndrome, digoxin toxicity that can present like that. This is a 3-year-old patient who had cardiac arrest during exercise, and you can see this is polymorphic. But when we do ECG, a patient clearly had long QT syndrome. This is another case. The patient had exercise and go into something like this. And she had a anomalous coronary artery. Another patient here, normal ECG, although, with T wave that's inverted in 1 and 3, prominent U wave. Patient went to exercise and had something like this. Looks like a bidirectional VT, although this patient also had ectropy and during sinus rhythm that during at rest, actually. Patient had Anderson-Tawil syndrome. CPVT usually will not have PVC during rest. Recently there is a paper on misdiagnosis of CPVT. They look at the PKP2, which is a gene that causes ARVD in patients who clinically diagnosed as a CPVT and found mutation in many of them, and also a case of sudden cardiac death in the young. So that would be one of the differential diagnosis. Not much on risk stratification. RI-R2 with neurodevelopmental problems seems to have more severity. History of cardiac arrest, early onset, absence of beta blocker treatment, and CASQ2 mutation seems to be more a malignant one. And I think I'll stop here, and then Dr. Yoshida will talk about treatment later. Thank you very much.
Thank you very much, Apichai. That was a great talk. I think we're going with Andrew or with Yoko first. What was it, genetics, or in one program it says one the other? Andrew, you ready to go?
I'm ready to go.
Okay, so Andrew Davis is not only my colleague at the RCH and at the University of Melbourne, he's also the father of our multidisciplinary clinics for cardiac inherited disease and a very keen researcher in this subject with a number of important publications you should look up. He's also famous for giving great talks with slides packed with information. You will see that. So enjoy the upcoming talk about the utility and the challenges of genetics testings in CPVT.
Yeah, are we checking, are we sharing the
Yeah, it was
screen?
there for a second, yeah.
Okay.
We
got the, okay. So thank you very much for inviting me, and I'm pleased that everyone could come during these difficult times, and I wish you and your families and friends all very well and be well. The utility for genetic testing in CPVT is immense, but so are the challenges. And the more we go along and learn things, the more we find we don't know. Genetics has helped a lot with disease definition, classification and understanding, and in this diagram just about idiopathic VF, you can see that CPVT was clinically separated from there in 1978, and various conditions have gone in and out of that category, including DPP6 and calmodulin, or some forms of calmodulopathies into IVF. So we learn a lot from genetics about classification, but there's lots of overlap. And Andreas led a review of CPVT recently, and he called it Time to Explore the Dark Side of the Moon, and it's really highlights how many things we don't know and all the things we have to work on in this very complicated and interesting but very important disease. And it's 20 years already since the RYR2 mutations were found to underlie the majority of cases of CPVT, about 65%. It's gone very quickly, and there are considered to be two main forms, and the RYR2 mutation some people call CPVT1, and the calsequestrin recessive mutations occur in 3 to 5% of patients, but as we'll see, calsequestrin also has an autosomal dominant form. Interestingly, patients who have the ryanodine receptor mutation are not at increased risk when you compare them to gene-elusive patients with CPVT. But patients who have recessive CPVT with calsequestrin, they seem to have a more severe phenotype. With the increasing availability of genetic testing, there's really been increased confusion and perhaps overdiagnosis. And when this group looked at the large exome databases, they found there are a lot of variants in RYR2 just in the normal population, suggesting that they're not necessarily the causes of CPVT in patients that we find. And one of the reasons for that is that the RYR2 is one of the biggest genes in the genome. And as genetic testing's been more available, there's been increased usage among weaker cases, and this test has a very high signal to noise characteristics, or a lot of noise compared to other genetic tests. Whereas initially when they did the testing, they just looked at the hotspots where most of the mutations are. Now when they look at the whole gene, it hasn't really helped. It's really increased the noise. So when you do get a gene mutation, you've got to, in a multidisciplinary setting, discuss with your team and scrutinize the data very carefully, and especially when the variants are outside one of the hotspot regions. So now, looking at this nice diagram from Peter Schwartz of all the channelopathies, I've tried to circle in red those genes that are known to cause CPVT, and so we'll go backwards, and in blue some of the genes that are phenocopies, and there might be others as well, and we'll move through some of those. Just to show that these other gene causes are all very rare, but obviously if your patient has them, there might be specific things you can learn. So first of all, with calsequestrin, that's usually the autosomal recessive form, but the International Registry has just found a number of families where this acts as an autosomal dominant disease, and the interesting thing is that that's just in various locations of the gene. So the autosomal recessive are in some spots, and the autosomal dominant in other spots are related to the location and function of the gene, which is very interesting. And that leaves the need to screen those individuals who were previously thought to be carriers. And what this team has suggested, that all individuals who have a pathogenic calsequestrin variant need to have a clinical evaluation and exercise testing, and perhaps repeat exercise testing, which is a little bit different to patients who have a definitive gene mutation in, even if they were phenotype negative, the recommendation at the moment is to treat them, and that's something maybe we can talk about in the discussion. Want to move on and talk about the calmodulin genes. Now, the calmodulin causes a number of nasty arrhythmias, especially in children, and there's a CPVT phenotype, there's a long QT phenotype, a mixed phenotype, and also an idiopathic VF phenotype. And there's a beautiful review that Susan Etheridge has just published, and the calm CPVT missense mutations can be in any of the 3 calmodulin genes, and the CPVT mutations are in particular spots, and they're in a different spot than the long QT mutations. One interesting thing is in calmodulin CPVT that bidirectional VT is rare. And we know that calmodulin long QT is very severe, and the calmodulin CPVT is also seems to be more severe than classic CPVT, so to speak. Trinidine, or some people call CPVT4, it's a component of the release unit, and there's a when that function is missing, or trinidine knockout syndrome, and it gives an autosomal recessive disease, and we need to consider that when we don't find a classic gene mutation, especially when it looks like the inheritance might be recessive. And an interesting thing for us to know clinically is some of those patients have skeletal muscle weakness. Turkle, another recessive one that has features of both long QT and CPVT, normal baseline QT, but the adrenergic induced QT prolongation, then arrhythmias, and then there's research done from the specific disease, pluripotent stem cell cardiomyocytes, that show that fleconides are therapeutic for this condition. And we need to think about this as well, even though it's very rare. Here's my patient with Anderson-Tarvel syndrome that's a phenocopy, and I think the ECG is almost exactly the same as APHRS showed, with often a right bundle branch pattern and bidirectional VT at rest, which is a phenocopy from KCNJ2. And some people refer to that as CPVT3, but it's not really a CPVT. It's its own condition, and clinically, the ventricular arrhythmias with right bundle morphology were more frequently observed at baseline, suppressed with exercise and increased at recovery, as compared to that provoked as in CPVT, and often with a left bundle branch morphology. We already had some mention of ARVC genes, and in thinking about being very careful in assigning a variant as causation, the RYR2 is now being entirely removed, just with this recent publication, as a cause of ARVC. Any patient who has RYR2 does not have ARVC, and it's just very interesting reading this paper to say when they looked at it carefully, that all literature asserting ARVC causality was judged to be incorrect based on incomplete phenotyping, wrong interpretation of data, use of dated diagnostic criteria, and designation of relatively common variants. So we've got to be very careful and very humble when we do our interpretation. And I always think about genetic interpretations as having a use-by date, just like eggs. And we need to go back and look at the information again with as understanding improves, and it's changing very rapidly, as you all know. There are criteria for diagnosing how certainty of genetics, and that's all best done in a multidisciplinary setting. But in this very interesting recent paper, what they've added to the genetic classification, they've added a clinical scorecard. So these are pathogenic and likely pathogenic. These are variations of unknown significance, and these are non-pathogenic ones. And if you add the clinical data in the score sheet, it increases your classification, improves your precision. And that's all basically what we do in the clinic, but it's been formalized for CPVT. And I think there's going to be more of that in the future for lots of genetic diseases. At the moment, and this is something we can talk about in the discussion, all patients who have genotypically diagnosed should receive therapy. And we can talk about, because we have no risk stratification, even if they've got a negative exercise test, and we can talk about that and also the age that we might begin that. And another important thing is that if we can for certain or diagnose with certainty that someone's got CPVT, then that might, as we're going to hear from Yoko, might help us to avoid a defibrillator, which is very important, or think about selective sympathectomy. And also helps us be very specific about activity prescription when exercise, as in this case, can be bad for you. And also just to mention that we're on the cusp of genetic therapy, and Sylvia Priory's group has cured mice with CPVT with gene therapy, and that may one day be available. So that there's been exponential development before our very eyes. It's allowed definition, classification, and understanding, but we have to be very precise in our genetic diagnosis and keep reviewing the meaning of the data, and a multidisciplinary approach is essential for that. And genetic diagnosis may allow release from follow-up, lifestyle modification, pre-symptomatic therapy, ICD avoidance, and specific therapies such as nadolol, flecainide, and cardiac sympathectomy. And here are my colleagues from the International CPVT Registry, who that's Christian van der Werf, and he's collecting lots of data from all around the world, and I think the more and more interesting data is going to come from that. So thank you very much for your attention. I look forward to the discussion, and I wish you all good health.
Thank you, Andrew. Dr. Siala Kudri will introduce the next speaker then. He's here.
Yeah, I'm here.
You want to introduce?
Yes. Welcome, Dr. Yoko Yoshida. She's a pediatric electrophysiologist at the Department of Osaka City General Hospital, Japan. She has an extensive experience in management of pediatric arrhythmias. She is an interventional cardiac electrophysiologist at the same center, and she had various publications in genetics as well as a catheter ablation. We are happy to have her here to talk on treatment of CPVT, and over to Yoko. Thank you.
Can you see my slide? Okay.
Yes.
Thank you, Dr. Yara Kudri, and thank you very much, Dr. Kramer and Dr. APHRS. It's a great honor to have the opportunity to speak at this seminar. Actually, I'm a little nervous talking in front of such authoritative doctors, but I'm so excited. In this presentation, I would like to focus on the recent evidence-based treatment of CPVT. I will also share some tips that we experienced from our 13 CPVT patients. It may be too basic for some audience, but I hope it will make sense for general cardiologists. This slide shows the ICD recommendations stated in the current guidelines, published in 2017. ICD therapy is a class 2A indication for CPVT patients who have recurrent syncope despite optimal medical therapy, or LCSD. As you know, ICD therapy is basically a class 1 indication to reduce the risk of sudden cardiac death in patients with various cardiac disease. However, in patients with CPVT, ICD shocks are sometimes not effective. To make the matters worse, it can cause electrical storm. In 2019, striking data was reported. This study is from a worldwide registry that including 136 CPVT patients who presented sudden cardiac arrest. 58% of eligible patients were implanted ICDs. During 4.8 years of follow-up, 3 patients died in the ICD group, while there was no death in the non-ICD group. This study found that ICD therapy did not provide a survival benefit in CPVT patients. If so, what is the optimal medical management to avoid ICD implantation? Currently, it is considered to consist of beta blockers, flecainide, lifestyle change to remove triggers, and LCSD. Let me begin talking about beta blockers. Beta blockers without intrinsic sympathogenic activities are the mainstay of CPVT treatment. Beta blockers have class 1 indication for symptomatic patients. This is some evidence to suggest predominance of nadolol. In 2016, Lauren reported that nadolol was superior to beta-1 selective blockers in reducing the frequency and severity of ventricular arrhythmias during exercise stress tests. Nadolol is available in Japan, and we prescribe it as a first-line drug. This table shows the characteristics of each beta blockers. Nadolol is a non-selective, lacking intrinsic sympathomimetic activity, low lipid soluble, and long-acting beta blocker. We sometimes prescribe sustained-release propranolol alternatively. Unlike nadolol, it is highly lipid soluble. Carvedilol has a unique property that acts directly to ryanose receptor. It reduces calcium ion release from endoplasmic reticulum. Bisoprolol is beta-1 selective blocker. We used to prescribe it, preferring its long-acting properties, but now we usually do not use it. In the treatment of CPVT, beta blockers are titrated up to effective levels. It is usually requiring high doses. This may cause side effects in some patients. This slide shows the side effects of beta blockers that our patients experienced and that required therapeutic interventions. 2 patients had frequent urination, and 1 patient became depressed. These symptoms were improved by changing or reducing the dose of the causative beta blockers. Patient number 2 had fatigue due to severe bradycardia and was implanted with a pacemaker to continue beta blockers. We cardiologists are familiar with cardiovascular side effects such as bradycardia or hypotension. However, we may not be sensitive to other side effects in patients. Symptoms such as bronchial asthma, frequent urination, or diarrhea are side effects of beta-2 blockage. On the other hand, highly lipid-soluble drugs can cross the blood-brain barriers and cause neuropsychiatric side effects such as depression state, insomnia, or nightmares. As will be discussed later, adherence to medication is one of the most important issues in therapeutic management. Detection of uncomfortable side effects is important. We should avoid patient discontinuation of drugs on their own. It is necessary to conduct a detailed interview with outpatients. Let's move to next topic, flecainide. Flecainide is a class 1C antiarrhythmic, commonly known as a sodium channel blocker. It also acts directly on open-state ryanodine receptor to decrease calcium ion release. In this guideline, flecainide is listed as a class 2A drug for patients refractory to beta blocker. This slide shows the result of multi-center single-blind placebo-controlled crossover clinical trial that secures strong evidence for the combination therapy of beta blockers and flecainide. Combination therapy significantly reduced ventricular arrhythmias during the exercise stress test compared to placebo on beta blockers or beta blockers alone. In this study, the target trough level of flecainide was set at 500 to 800 nanogram per milliliter. The right column shows the dosage and serum levels of our patients. Previous in vitro studies have shown dose-dependent response of the effect of flecainide on spontaneous calcium ion release from endoplasmic reticulum. Therefore, the serum levels of flecainide should be carefully monitored. There are some other important points to consider in the actual drug treatment. This survival curve on the left shows the cardiac event after initial diagnosis observed in our 13 patients. The 5-year event-free rate for all cardiac events was 84%, and cardiac events can occur even when patients appear to be stable with treatment in the remote phase. This pie chart on the right shows the medication status at cardiac events. 40% of cardiac events were due to poor medication adherence, and 20% were due to an intended reduction of drugs that were not adjusted patient's body growth. Although it is not widely known, some patients with CPVT have neurodevelopmental problems, even without major ischemic brain lesions. If their symptoms are mild, they are often overlooked. Some patients have hypersensitivity issues like ADHD, so changing the dosage from can make it impossible for them to take the essential drugs. We should be careful when explaining the importance of drug medication and changing dosage form. We believe that regular measurement of the serum levels of flecainide is a good practice. The dosage of drug should be adjusted as the patient's grows. And even if a patient seems to be stable, decreased drug adherence can occur at any time. We should try to detect it in the early phase through blood tests. Next topic is lifestyle changes to remove arrhythmic triggers. In the previous cited guidelines, exercise restriction is recommended as class 1 in all symptomatic patients. However, for adolescents, this may be completely acceptable. If they stop coming to the hospital because of the strict exercise restrictions, it defeats the purpose. The Mayo Clinic retrospectively investigated the prognostic impact of sports participation in patients with CPVT. 38% of eligible patients participated in various types of sports at the type of diagnosis. After initiation of the optimal treatment, 88% of the athletes continued competitive sports. Compared to long QT syndrome athlete patients, the incidence of cardiac events were higher in all CPVT patients. However, during the follow-up period, there was no statistical difference between the non-athlete and athlete CPVT group. There was no event resulted in death. They controlled that the risk of sports participation may be acceptable for well-treated and well-informed athletes. We believe that it is important for the patient to feel that he or she is the center of the treatment and to feel they can control themselves. To encourage patients to participate in treatment, we tell the patient the heart rate range that we consider to be safe. we ask the patient try to keep their heart rate within the range. Using these devices, such as Fitbit, tracking heart rate may help detect the risk in daily activities. These days, another risk is hidden in children's lives. Playing video games may have become an enjoyable hobby for CPVT children for restricted exercise. However, this slide shows a case report of Fortnite VT in CPVT patients published last year. Fortnite is some of online battle royale games. We have similar case of Nintendo VT. That's why video games should be played under the watchful eyes of patients. The restriction of excitatory activities makes sense considering the pathogenesis of CPVT. However, further research is needed on the effect of restrictions. Shared decision-making is important to improve adherence. Thus, the last topic is LCSD. In the previous cited guideline, LCSD are stated as Class 2A recommendation in symptomatic patients despite optimal medical therapy. The risk of complications such as Horner syndrome is thought to be lower if it is performed by experienced surgeon. Unfortunately, in Japan, this surgery is not so popular. I'm afraid we have no experience in our hospital. This slide shows the result of worldwide cohort study that investigated the efficacy of LCSD in patients with CPVT. Included patient numbers was 63. The post-surgical follow-up was 37 months. The bar graph on the right shows the incidence of major cardiac events before and after surgery in symptomatic patients despite optimal medical therapy. 67% of patients who had major cardiac events became asymptomatic after surgery. LCSD seems to be a promising treatment that should be widely performed. In conclusion, comprehensive management of combination therapy with beta blockers and flecainide, lifestyle modification, and LCSD are the most appropriate treatment to avoid ICDs. We must strive not only to improve the prognosis of our patients, but also to maintain their quality of life. We need to ensure that our CPVT patients receive the most appropriate treatment at all stages of their healthcare journey. Thank you for your attention. Thank you.
Thank you, Yoko Yoshida, for your nice review of the treatment in CPVT. So we'll have a lot of questions to answer later. I think we'll take them after the last talk by Dr. Skinner. I'll request Dr. Andreas to introduce John Skinner and go ahead with the next talk, and then we'll come back to question and answers. There are a lot of questions, so we'll answer them at the end of the session.
Thank you very much. John Skinner has not only been doing great work, first in the New Zealand area with bringing up the sudden death as a really important problem, first nationally and then later expanding the work in the whole ANZ area. And he's a professor at Auckland University and recently decided that he comes to the good side of the ditch and comes over to Australia. Unfortunately, he didn't come to Melbourne. He's in Westmead Children's Hospital. He's really a great teacher and I've been benefiting from his talks frequently. And he will showcase today how to handle difficult cases. So John Skinner, we're looking forward for your talk.
Thank you very much, Andreas. Can you hear me?
Perfectly.
Thank you. Okay, well, I'll try and share my screen. Let's see if that's going to work for us. Can you see this now?
Yes, perfectly.
Thank you. Okay, well, thank you, Andreas. And thank you, APHRS, for organizing this lovely conference. First of all, you may notice that my background is a picture from the old Delhi Bazaar. And this is a fond memory of Andrew Davis and I when we visited that region. And it's really just to express my solidarity with you guys in India who are having a really terrible time at the moment. All of us feel for you and look forward to you coming out of it the other side. So now, that was a wonderful talk, Yoko. Congratulations on that for such clarity. I think that was magnificent. So what I want to do is we've had a lovely roundup of CPVT. Now I want to take this to the clinical coalface a little bit and talk about some interesting challenges that we get when we're dealing with these this sort of issue, the catecholamine sensitive VT. So the first question is catecholamine induced VT or cardiac arrest always CPVT? And do healthy people get short coupled ventricular ectopy on exercise? Picture me of they're supposed to represent me. I think the reason I'm asked to give this sort of talk is because I'm old and I've been doing it a long time. I'm actually no older than Andrew, though. You're looking very young, and that just depresses me a bit there, Andrew. So here we are. We've seen this. This is a case of a young man who had a sudden collapse. And often, as you've seen with CPVT, you start to see monomorphic ventricular ectopy, quite typically coming from what looks like the right ventricular outflow tract. But you may or may not see this. And this young man, of course, went on to have a syncopal episode. So was this CPVT that he was suffering from? When I do any work giving a talk, I always make sure I look up work by Sami Viskin. He's an extraordinary adult electrophysiologist who's really brought this field forward so much in so many different areas. And one of the areas he was looking at was idiopathic right ventricular outflow tract tachycardia and how it's sometimes associated with VF and cardiac arrest. You know, we all know that these outflow tract VTs are usually benign. Usually you've got plentiful ectopy, often visible throughout the day on your Holter. But in idiopathic VF and polymorphic VT, as in Brugada, the ectopy is usually quite rare and it's very short coupled. And what Sami did in this case series here was presented cases of right ventricular outflow tract tachycardia which had a malignant course. Now they were adults, but there's stuff we can learn from this. And essentially, the bottom line is that malignant right ventricular outflow tract ectopy was characterized by a coupling interval of less than 390 milliseconds and the presence of an R wave on T wave on the Holter. Now, of course, less than 390 isn't actually that short in pediatrics. We will often see young children with coupling intervals of 250, even in relatively benign forms of outflow tract VT. So we have to find our own numbers. I don't know if there is a magical number, but I'll show you some examples where clearly that number was exceeded. So how common is it to see short coupled VT on exercise in children? Well, this was a report of over 1,000 exercise tests in children done for a variety of reasons you can see on the slide there. Third of them for chest pain, syncope, 10%. And this is the result of those exercise tests. You see, there was only 5 cases of those with clinically significant arrhythmias, so 15% who had VT. So it's pretty uncommon in children in the general, for the general pediatric cardiologist. And the things that made you more likely to develop significant arrhythmias were the things you might have expected. So the presence of severe left ventricular dysfunction, pacemaker, and the history of an arrhythmia and not having sinus rhythm at rest. But most of these exercise tests, of course, were not done for family screening. And this is something that we're doing now more and more. We may have a parent or brother or who's had some sort of malignant event, maybe even a sudden death. And now we find ourselves doing an exercise test for that reason. And we're starting to turn up all sorts of results, which you might term variants of uncertain significance, in the same way as you would for a genetic test result. You get a variant result. Does it mean they have the disease? Well, I guess the lesson is you must always expect the unexpected. And a CPVT is one of those conditions that Andrew alluded to, where really you have to be thinking about it all the time or you're going to miss it. But at the same time, it's really important not to overdiagnose it. So this is a child who was an 8-year-old who had a syncope riding a bike. He was actually found on the side of the sidewalk with his bike beside him, unconscious. He came round spontaneously. We did this exercise test, and we can see very clearly bidirectional VT. And this was a boy who turned out to have CPVT. He's done very well. And you know the stages. First of all, they get the single ectopy, then you can get the bidirectional VT, and then this can generate into polymorphic VT. We've talked a little bit about the differential responses. I just want to mention Anderson-Tawil, as alluded to by Andrew, because it is a bit different. One of the features, if you look at that graph on the right side there in figure A, in Anderson-Tawil, they get ectopy quite a lot at rest and early on in the exercise test, whereas CPVT tends to come on later and come on quite aggressively. So VPBs in CPVT quite often come quite late in the exercise test. Now here's a real life clinical scenario. A 13-year-old girl with vasovagal syncope, absolutely classical, no question that this was vasovagal syncope. But the reason I did the exercise test was really just to reassure her that it was fine for her to go ahead and do exercise. There's often a lot of anxiety around these cases. They've been having syncope sometimes for months or even years. Then it turns up that you can see on the right there 3 fairly short coupled ventricular ectopics, and they're multifocal. So what does this mean? There was no family history. There was a normal echocardiogram and an MRI. And we went forward and did a genetic testing because I thought this was sufficiently unusual. But interestingly, you will note that at peak exercise, there was no ectopy. This was on the way up there at 3 minutes that she had these unusual ectopics. A 14-year-old female with dreadful postural tachycardia syndrome underwent routine tests to reassure her. There's another one. There we are. Very short coupled, this time in recovery. You can see that in the Bruce on the right there, 1 minute into recovery, a short coupled ventricular ectopic. And on a Holter, you can see these, what look like polymorphic ventricular ectopics. No family history, MRI and echo normal. She can't take a beta blocker. The slightest sniff of a beta blocker drops her blood pressure even more. So what does this mean, and what do we do about it? I'll come back to that. Here's a 12-year-old boy who had exercise-related syncope. Very dramatic. He played rugby. He was a Polynesian boy. When we did his exercise test, he suddenly developed this rapid, what looks like right ventricular outflow tract VT. He lost consciousness. He fell off the back of the treadmill. That happened so quickly. He made a hole in the wall at Green Lane Hospital many years ago. He made a recovery. He didn't have a serious injury, but everybody was quite shocked by this. I took him to the lab and did a successful ablation. It was a bit scary because during the burn, he developed VF, but he's 30 years old now, and he's had no symptoms at all since that successful ablation. So here was a treatable catecholamine sensitive rapid VT, which wasn't what we would term CPVT. So this was a case that was, thanks to Dominic Abrams from Boston, showed me this. This was a 19-year-old elite athlete undergoing a screening exercise test, and he had this very frightening looking VT. He had some palpitations, but he'd never had any syncope. And the question is, what does this mean? Well, of course, he had no family history. A repeat exercise test was completely normal. The MRI was normal. He even had an EP study, this lad, and induced nothing. A reveal was implanted, and he's continuing to do elite athletics. Now, how can we allow that? Well, the fact of the matter is that such findings in cases like this are actually not rare. They're uncommon. So this is a report from in the Heart Rhythm in 2015, which looked at exercise ECG testing in 5,000 consecutive athletes without heart disease. And they were analyzed for the occurrence of ventricular arrhythmias. And you can see on the face of it, those results look pretty frightening. There's even on the left-hand panel there, what looks like a bidirectional couplet, and short coupled in the panel B. But of all of those, these 36 athletes were banned from sport. but their repeat exercise tests were normal. Their repeat exercise tests a year later were normal, and 6 of them went forward to have a right ventricular outflow tract tachycardia ablated, but there were no adverse events in the whole group. So what this shows us is that when the pre-test probability is low, you can occasionally see ventricular ectopy and short runs of VT like this, which can be frightening, but it doesn't necessarily mean you have CPVT. Although, of course, you need to go through all the motions of checking for family history, repeating the exercise test, and getting very high quality imaging. This is a 12-year-old boy with rapid palpitations during sport, felt dizzy and short of breath, lasting up to a minute. And this is my colleague Christian Turner's patient. And there we are into recovery. And look at that rapid VT there. Again, looks like right ventricular outflow tract, extremely short coupled. Now, negative family history, normal MRI, negative EP study with a lot of isoprenaline and adrenaline given. He had normal endocardial EP mapping, and he had a full genetic screen was negative. Now, he's been managed with beta blockers. He's been on the beta blockers for 3 years, and he's doing well. I don't know what else we should do. On the other hand, I want to make this little point that exercise testing in people with arrhythmogenic right ventricular cardiomyopathy, if you see, you can even have that condition, and sometimes the ventricular ectopy can even suppress at peak exercise. And this conclusion from these 3 cases from this very experienced group in Toronto was that complete suppression of VPCs at peak exercise can occur in people with ARVC, in children with ARVC. So the disappearance of ectopy might not always reassure us that there isn't a malignant condition behind it. One thing I will mention is the plakophilin-2. If you have any patients who have plakophilin-2 and ARVC, this is a group that are a perfect phenocopy almost. They present like CPVT, and their MRIs might be normal to begin with, but some years later they will tend to become positive. So that's just something to tuck away there in your memory banks. PKP2 tends to behave differently from other forms of ARVC. Now, I show this case of, why do I show this case of a 32-year-old man? It's because it makes an interesting point. This man came to me. I used to deal with quite a lot of adult congenital patients as well. And he came with symptomatic ventricular ectopy. He was getting palpitations. And on echo, he had mild to moderate right ventricular dilation, but he had a totally anomalous pulmonary venous repair as an infant and had done well. And he had his right upper pulmonary vein left draining to the SVC. It was quite remote from the heart and felt that it could not be fixed. But he was fit and well, lawyer, doing well in his life. But there was this ectopy. So at peak exercise, you see, he was getting runs of VT. So we took him to the lab, and he had grossly abnormal endocardial map with several different ventricular ectopics from the right ventricular outflow tract. We ablated the dominant focus, but he had a cardiac arrest 2 weeks later, which thankfully he was resuscitated from. And he gradually developed arrhythmogenic right ventricular cardiomyopathy. In fact, both ventricles involved over 10 years. And he's had a transplant since, and he's doing well. Why do I show this case? Well, you know, one of the words of wisdom from one of my American colleagues, you can have fleas and lice. You know, just because you have congenital heart disease doesn't mean you can't have an inherited cardiac condition or some other acquired condition as well. Now, my last case I want to show you is a 14-year-old male who presented to me a month ago. So he's previously well. He was running on the beach with siblings and suddenly collapsed face down into the sand. He had effective CPR, fortunately delivered by bystander nurses. He had an external defibrillation retrieved from the life-saving unit nearby. He had one shock to revert his VF to sinus rhythm, and he was so successfully resuscitated that he returned to consciousness in the ambulance, and he made a full neurological recovery. And when I saw him on the ward, he was fully coherent and just surprised to be there. Now, of course, we did all the investigations. The family history was negative. Mother, father, and siblings had a normal exercise test. His MRI was normal. His echo was normal. His ECG was normal. But his exercise test wasn't normal. What you'll see here is that there is ectopy in this case, coming with every second beat, you'll see that he's having broad complex ventricular ectopy. And you'll see that it's a kind of superior axis, right bundle branch block type. And here we did it again with the sprint protocol, where we get them to run as fast as we can, as quick as we can. And you can see on the right there that there's this very short coupled ventricular run. Now, this doesn't look unlike some of those cases where we think there's a benign course, but clearly this lad is presented with VF arrest. So in summarizing those things, monomorphic PVC suggesting possibly a left posterior fascicle origin, more marked with one very short couplet. And when we put him on flecainide, everything completely disappeared. Now, we did a broad cardiomyopathy arrhythmogenetic panel, and that came back quickly. There was nothing in RYR2 or CASC2 or anything like that. He had a variant of uncertain significance in T-box 5, but he had no features of Holt-Oram syndrome. So that was probably not relevant. And it's just that this case reminded me so much of the fairly typical fascicular VT. And this was a 7-year-old boy that had exercise-related tachycardia, which was a fascicular VT, which we ablated successfully. So we took this young man to the lab. He had, this was only this week, and he had normal endocardial mapping, but this PVC that we saw at the beginning resembled very much what we saw in exercise test. And he had one episode with isoprenaline of rapid, non-tolerated VT, which looked like that. Again, superior axis, right bundle branch block pattern, appearance very similar to the ventricular ectopics. So we decided to try to ablate this. First of all, the first ectopic was associated with a Purkinje fiber. We thought we'll take a classical approach, and we did an ablation here. Had no effect. We decided we would transect the Purkinje, the posterior fascicle here, which went forward successfully. We ablated that. And then we've ablated the earliest origin here with complete disappearance of the ectopy, and on isoprenaline, he had no ectopy or VT at all. Now he's recurring very nicely. We have put an ICD in place because clearly there's some risk, but I think this boy has a malignant form of fascicular VT, which has been described only in a handful of cases across the world. That's our pace mapping from the best site there. So is catecholamine-induced VT or cardiac arrest always CPVT? No, it isn't. Do healthy people get short coupled VE and even sometimes short runs of VT on exercise? Yes, they do. So what sense do we make of this? What are the lessons? So VT, even short coupled on exercise, is not always malignant. You need to find out though, is it truly unexpected? We need to check the clinical and the family history. Could it be familial? You need to make a full family history and consider the investigation of family members. Is there ARVC in the parent? So an MRI in the parent, perhaps. Thorough examination of the child is really important. Do they have curly hair, thick skin on the feet, as in Naxos disease? Do they have features of Anderson-Tawil or skeletal myopathy? With no clinical or family history and all the tests on the child and the family are negative, it's most likely not malignant, provided it's been presented as an incidental finding. And this context of this concept of pretest probability is something that we discussed when it comes to interpreting the length of the QT interval in that article I've listed there. Some other final lessons. Catecholamine VT is not always CPVT and it can sometimes be ablated. So I've had 2 in my career, and I know some have had more than that. Genetic testing is now carrying an increased value. And if that boy had an RYR2 variant, then clearly he would have had CPVT given that he presented with a cardiac arrest. And I might not have taken him to the lab, but I think his VT was atypical for CPVT. Thorough imaging is obviously very important. Could this presentation be an early cardiomyopathy? And if your exercise test is negative, try a sprint test. This has been recently validated by Andrew Cran in a recent publication from Canada. So thank you very much. I'll stop now and I look forward to dealing with some of those interesting questions that have been presented to us.
Thank you, John. That was really great. I think we have quite a few questions actually, and I encourage you to further put in questions. I think I would like to start off with some general questions which go into the direction of diagnose. There have been a number of questions. I try to combine them a little bit so they become more clear. So there's a good question reporting how to do the exercise test. You know, those kind of rapid increase in workload we talked about. Maybe we make that a little bit more clear what we mean with that. And then with a very clever question also, when do we stop? You know, do we wait till it becomes VTVF, or do we stop already with a bigeminy? But then what if the VT would disappear when we exercise further? So what's your kind of way to go forward with the kind of exercise test? What type of exercise you do? How do you stop it? Do you just do one exercise test? Very suggestive already.
So I don't know, Andrew, you've been doing some work on this over the years, haven't you? Maybe you'd be a good person to start.
So, well, we like to do a sprint exercise test, and it was something I heard about at Heart Rhythm but wasn't formalized. And I'd had a young girl sent to me whose mother had a diagnosis of sudden death in epilepsy and who'd collapsed in sport. And the paediatric team at the other hospital had heard my talks that we have to worry about collapse in sport. So we brought her over to our hospital and we did every test known to mankind and 2 Bruce protocols and nothing happened. So I just remembered that I'd heard someone say that you should try and sprint them. So we put her on the treadmill and we did a sprint, and before our very eyes she had a VF arrest. And that was before the days of gene testing widely available, and she subsequently proved to have RYR2. So since then we've been doing a lot of sprint testing, and we also use it for trying to optimize the beta blocker dosages in patients with CPVT, or to pick when we should add flecainide. So,
Andrew,
and I was very, very interested when I think the most recent publication called it a burst test, but I think it's when you do get a lot of catecholamines flowing. So that's what I like to do, but we haven't had the resources to do like a comparison to do it, and because you can't really do it on the same day because they'll be exhausted after either.
They're a bit tougher in New Zealand. We've done that a couple of times, I have to say. Andrew, how practically do you organise that? How do you make it actually happen on the day?
So we go into the room and we control the treadmill, and we watch the patient. We have someone there to catch the patient, and we put it up moderately steep and rapidly increase the heart rate according to the capability of the child. But I can usually do it from 7 or 8 years of age onwards, and we push them very hard, but obviously, and until they're almost tripping, and then we stop. And the question about when to stop, I think it depends why you're doing it. If you're doing it just to titrate your therapy, I think if you wouldn't need to push past the increased arrhythmias. But if you haven't got a diagnosis and the patient is comfortable, it might be worth pushing on a little bit, but it's a judgment call.
Mm.
So this is like a manual control, is that right?
Yes.
Yeah. And I guess the other question is when do you stop? When you see, you know, a few PVC, when you see bidirectional, or, you know, how long do you wait? I guess that's one of the questions. I think we, well, first I never do a splint test. It seems like something that, you know, we will try later. Because I know that, you know, there are cases that, like you say, the Bruce protocol doesn't bring it up, and, you know, you have to repeat it many times. And then actually, one of the questions I wonder is, you know, how many times do you do exercise tests and it's negative before you say this is not CPVT? But as far as when do we stop, I think it's different between the first test and the follow-up test. I think the first test you want to make diagnosis, so a single PVC wouldn't do it. So I do it until we see polymorphic VT. Oftentimes it will be bidirectional, and then usually patient will stay on the treadmill, nothing wrong with them, no symptom, then I stop. But when we do it as a follow-up, we like to suppress the PVC such that we don't have a couplet. So sometimes we do have a single PVC. So if we have a couplet, then we would stop and titrate the medication some more. So I don't know if other people do it the same way.
That's certainly the way that we would do it. Yoko, do you do the same?
Yes, in Japan, accessibility to the hospital is very good. So we repeat treadmill many times. But my opinion, Holter monitoring may be effective prior to treadmill stress test in small children.
Yes, so they can be they can get quite excited, can't they, doing everyday activities, even little toddlers and 4-year-olds and so on. Yeah.
Maybe give them a video game.
Yeah, yeah. Yeah.
Yes. So I wonder if anybody else has had any experience with the adrenaline challenge. I can just briefly give you my brief experience with adrenaline challenge. I only use it for when a child is non-ambulant, and for me that really means people who are in the intensive care and they're either going to have their treatment withdrawn. That's one group, they're brain dead. Or the other group is those that are on ECMO at the time, and you're really in a diagnostic conundrum as to where you're going to go with that child. So the adrenaline challenges I've used in that context, where I've clinically suspected CPVT, have been strongly positive. So these are people who've already had a cardiac arrest. This is not in the kind of your routine kind of assessment of syncope, and that's the only time I've used it. What happens is you give them adrenaline. If they had a recent cardiac arrest, they're on ECMO, they'll go into VF. That's my experience. And interestingly, one of them was going into polymorphic VT, and I gave flecainide, and it reversed it immediately. So it's almost like a reverse diagnostic test. You give flecainide in that situation, it shows it's CPVT. I don't know if anybody else has had experience of adrenaline. That was one of the other questions that came forward.
Yeah, our experience with adrenaline is the other way around, but it is exactly what you're saying, I think, depending on whom you test. So if you test someone, like you said, in the ICU, so we had some involuntary testing because people have been resuscitated and became a little bit more unstable, and someone started adrenaline and then they became unstable again. So we should talk about that anyway too. But if you have patients who maybe are just genetically positive, or we assume that they might be positive, and you test them with adrenaline, I think that's a pretty poor test in terms of whether they carry the gene. I think adrenaline in children might not cause that much of a change, especially when they're not in their kind of vulnerable phase. It's a little bit like doing a Holter in someone who just sits around. You might not get anything. Often those children even have to be under anesthesia if they're very young, or so that makes it even more difficult. So I think you have to be careful with a negative test, but I agree, if you have someone where you question it and you have a positive test, so the specificity of the test will be pretty high. Anyone else want to say something? I think Dr. Sachin had collected some more questions.
Yeah, I have questions here where when there's this question, I think Yoko can answer. What is the next best beta blocker when Nadolol is not available?
We believe that adherence is very important, so we prefer long-acting beta blocker, Nadolol or long-release propranolol, but it is a capsule drug, so it is not suitable for small children. Second drug is bisoprolol, but it has long-acting property. But next combination therapy, I have experienced bisoprolol and carvedilol. They are different effects for CPVT mechanisms.
Yes, that's really interesting because carvedilol actually has a direct action on the calcium release mechanism in the same way as flecainide does. But I've not actually had the opportunity to use or needed to use that yet. I don't know if anybody else has. I mean, in the lab, in vitro, it works extremely well. Carvedilol abolishes the after depolarizations.
Yeah, we have one patient on carvedilol due to his fact that he presented actually with a tachycardia-induced cardiomyopathy with atrial fibrillation. And,
right.
So that's another point I wanted to bring up also maybe next, but maybe some more people talk about the second change dose of beta blocker, because I think that's an important problem because nadolol seems not to be available in ZSANZ for quite some countries. So there are a number of questions about that. So everybody feels free to contribute to that.
I haven't used it, but I agree there's good literature. Carvedilol might be helpful, and it is readily available, and you could titrate it up and see and be very careful with the patient.
I think we could also learn a bit from some of your work, Andrew, because you know my suspicion about atenolol, that it's a pretty hopeless beta blocker, but you've actually proven in long QT syndrome that you can use it successfully long-term in children. And my own bias, I mean, I definitely say this is a bias, is that the reason that nadolol is so effective is less to do with its selectivity or non-selectivity. It's more to do with the fact that it's taken once a day. And its half-life is, 24 hours. So you can miss a dose or even 2 doses and you've still got nadolol on board. Whereas most of the others, you have to be much more obsessional about taking it, twice or even 3 times a day. And I know that when you've been managing your long QTs, you've been managing very closely with repeated exercise tests and halters and making sure they take the beta blockers. And I think that would be the lesson, that if you're going to have to use something else, they're going to have to take it twice a day, even bisoprolol. And so therefore, I think we're going to have to be a little bit more obsessional about making sure that they actually have their heart rates suppressed. And, nadolol, I relax. I think people do tend to take a tablet once a day. And the only significant side effect I've seen from it, other than the usual beta blocker thing when you give a bit too much, is hair loss. And that's something that's dear to my heart. But, so you can get the occasional patient who will lose their hair with nadolol. It's uncommon, but I've seen 2 cases where I've had to change it. So I think just give more and give it more frequently and monitor carefully if you have to use something else. And I personally would use either carvedilol or bisoprolol first.
I think there's the new data going to come from the CPVT registry that shows the nastier cases that nadolol's much better, even independent of medication adherence. And I strongly agree that adherence is very important. And so hopefully the nadolol become more widely available because of that.
Yeah, we generally use atenolol or metoprolol. I think the reason is we don't have nadolol. And a lot of time, well, at least previously, when the health insurance, the national health insurance doesn't cover bisoprolol, and so we are left with atenolol or propranolol, and as you said, adherence to therapy is very important. So we need to have the child taking propranolol, and then 3-4 times a day. Then when they are young, usually they're okay. When they get to a teenage year, they sometimes don't do that. And recently, I have a patient who skip his atenolol because he said he's fine, he didn't have any problem, went to play soccer and had cardiac arrest. And
yeah.
John, do you think there's going to come a time where flecainide monotherapy will be a treatment for some patients?
Yes, it's remarkably good, isn't it? I mean,
Yes.
in some, you know, it seems to just switch it right off. But I haven't been brave enough yet. I don't know if you have.
No,
and
I'm not brave at all.
No, I haven't been seeing the. I haven't. We'll start to see these the more mild cases. You know, the familial ones, rather than most of the cases of de novo. You know, they present between the age of about 4 and about 15, and they're presented with this profound syncope or a cardiac arrest. So I think as we see more and more of the mild cases, then I think we may have to start going down that avenue. And the other thing, just to respond to Apichay, I think you know, sympathectomy. I don't know if you've got a good surgeon who can do that for you, Apichay, but for me it's like a permanent beta blocker. And we've used it a lot, especially, in fact, we'll use it up front. When the patient tells me they're not going to take their medication, we'll do a sympathectomy if we can talk them into it. The biggest, when we've looked at non-adherence, this was mostly in long QT, but also CPVT, the most single modifiable factor, if you like, is the fact that they tell them that I don't think in my life I'm going to be able to take that beta blocker regularly. If the family tells you that, ask that question. If they tell you that, then I think they should get a sympathectomy, personally.
We had a question here about sympathectomy. Do you see more atrial fibrillation with sympathectomy? That was a question from the audience.
I haven't seen it. I don't know if anybody else has.
I think we tend to do sympathectomies in the patients who've got are more severely afflicted, and they tend to be the ones who have more atrial fibrillation. And I haven't seen it be helpful with the atrial fibrillation, but I don't think that's another thing we might get from the international registry. But atrial fibrillation becomes increasingly troublesome, and I think it reflects the more severe case.
Yeah. Mm-hmm. Did you want to, Andreas, you mentioned at when we were discussing pre-talk about cardiac arrest and the adrenaline issue?
Yeah, I think those two questions are still up. Is when do you suspect in a resuscitation that it's CPVT, and what's your resuscitation guidelines for patients with CPVT? I think that goes towards you. You published about that.
Yes. So it's not an easy question to answer because, you know, adrenaline is still very much in the advanced pediatric life support. You know, it's still part of your armamentarium. But I think what you have to have is your first responders and your emergency department and intensive care specialists aware that if you give adrenaline and you get VT, then don't give any more adrenaline. It's really as simple as that. I mean, if you've got a child over the age of about 3, because CPVT very rarely presents under the age of 3. If they present with a sudden cardiac arrest out of the blue with no previous history, they should be thinking, is this CPVT? And if they're giving adrenaline and there is VT, don't give any more adrenaline. It's an anesthetic they need. In summary.
Yeah, that's a very good answer. And I think it's also time. We actually have 1.5 hours already done. We had well over 100 participants. Now slacking off a little bit. We try to answer most of the questions, but we might not have been able to answer all of them. So I just sharing the screen. I don't know if you can see that. If you have any feedback, questions, comments, suggestions, or still unanswered questions, I'm very happy to forward them to the people who are the most adequate ones. I think it was a great success. Thank you, Apichay, for pushing us to do that. I don't know if Sachin wants to talk some words at the end.
Thank you, Dr. Apichai and the APHRS for organizing this symposium. Most of the questions are answered, and the questions still remain unanswered. The reason being it's a orphan disease, and then we don't have a randomized controlled trials, and we cannot have as well. It comes from all the small studies and the clinical case reports. So we keep learning. As we keep learning, we get the answers on that. Some of the questions are not answered. I think we'll take them and individually post to you people. There are especially on the therapy of this. So to summarize all this about the therapeutics, I think the beta blockers are the first line therapy. And then if you don't have nadolol available, as it happens in most of the South Asian countries, we also don't have nadolol. We start with the propranolol sustained release and go ahead with other drugs. Flecainide is reasonably available as a next line. And sympathectomy can be done in many of the centers with the expert surgeons. That would be the next choice. ICT comes in the last line. And the calcium channel blockers, there is no real data. That is a question being asked here. There is no real data on using a calcium channel blockers. And also we don't have answers regarding the phenytoin in terms of any reports. But as it is a delayed after depolarization, it may act. We may have to try it in the future. Thank you very much for all the participants and APHRS, especially organizing Secretary Chairman Dr. Apichai. So over to Dr. Apichai for closing remarks.
Oh, yeah, well, nothing much. You know, I think one thing we probably should touch on a little bit is, you know, how do you program an ICD? Because, you know, remember when one of my very first patients, the ICD was programmed as 2-zone, you know, VT and VF. And then, you know, when patient wake up, she was in pain and then had lots of VT and then chopped VT and never could stop VT. It's only when patient went to, patient actually did fine, but I would say, you know, when you program the ICD, I generally just do 1-zone VF and don't try to shock any VT. Is anybody had any thought on that?
Well, I think it's best. Sorry, it's best to best to avoid the ICD as much as possible, and then if you have to have one, to have a no anti-tachycardia pacing on, and to have the detection very long.
Yeah.
Yeah.
So the ICD just doesn't work for polymorphic VT, but it works for VF. Oh, yeah. So you have to wait for it to degenerate to VF.
So VF zone only, right?
Yeah, VF zone only.
Okay. All right. I think that. I think we should close the session. It's 3 minutes over, but you know, I think there's a lot of good talk and you know, experience going in here. I learned something here too. Thank you very much, and back to you, Angus. I guess we can stop it, right?
We can stop now, yeah.
Okay. All right. Okay.
Well, see you. Bye, everyone.
Goodbye, everyone. We'll see you.
Thank you for organizing it.
At the APHRS this year, which will be a hybrid, have online and have, you know, in Shanghai. I don't know if we can travel by that time, but, you know, we'll see you then.
See you.
All right. Thanks a lot.
Keep well.